my colleagues only ask me how to join, and then how many people, and they're surprising more than 2,000 joins, and then
2,000.
see how, and then now reaching 3,000 something. But yeah, because it's very important, especially in this time around, we are really depending on the auscultation, because doing other methodology to screen our patients sometimes quite dangerous,
Yeah.
Yeah, still a couple times. Okay, I think we are already reaching 1 p.m. We'll start, right? Everybody okay?
Right.
Okay.
Yeah, Dok.
Okay. Right. Assalamualaikum warahmatullahi wabarakatuh. Very warm good afternoon, my colleagues, ladies and gentlemen. I will mix my language with bahasa as well. Selamat siang sejawat sekalian, dimanapun berada ya, kita akan pakai mix language nanti kalau ada hal-hal yang khusus kita bicarakan. Oke, selamat datang di acara Cardiac Auscultation Session. So welcome everybody, dear colleagues, to the Cardiac Auscultation and Heart Sound International course that what we call. So as you know, everybody, we are now in the era of the pandemic. So it is very important for us to keep improving our skill, such as understanding well how to do right cardiac auscultation and to hear the real heart sound. And this pandemic bring us to the time in which it is increasingly important to have our basic skill to do our diagnosis with our ear, with our eyes, to do a better diagnosis our patient at first, because sometimes it's not easy or not really convenient to do additional examination in the era of COVID-19 pandemic this time around. So this event is held to celebrate actually our anniversary of National Cardiovascular Center Harapan Kita, Pusat Jantung Nasional Harapan Kita in Jakarta, Indonesia, and also the Indonesian Heart Association, as well as celebration of the anniversary of Department of Cardiology and Vascular Medicine, Faculty of Medicine, Universitas Indonesia. So this event is held under collaboration with Department of Cardiology, Padua University, or you can call in English Padova University. I would welcome the presence of our instructor today, Professor Sabino Iliseto, MD, PhD, a well-known cardiologist in Europe who already joined our today's session. This educational event obviously cannot be undergone without a great support from Daria Varia Laboratoria. Daria has always provide a real commitment to increase our knowledge and awareness of Indonesian doctors in all fields. Okay, my colleagues, ladies and gentlemen, at first we will hear the opening speech of today's event from our President Directors of National Cardiovascular Center Harapan Kita, Dr. Iwan Dakota, consultant cardiologist. He's consultant cardiologist at Harapan Kita National Heart Center with subspecialty in the intervention of peripheral heart disease. So he's doing a lot of work, peripheral vasculature in some difficult cases, and he's also serving as our President Director. So please, Dr. Iwan, time to you to have your opening speech.
Hi. Well, thank you very much for the giving opportunity, Dr. Renan. Can you hear me very well, right? Okay.
Yeah, it's clear.
Okay, first of all, let me say thank you very much for the giving opportunity and to the organizing committee. And yes, first of all, good afternoon to the all participants, colleagues, And good morning to Professor Elisito from Padua University. Well, this very important course, this is what we call the serial interactive virtual learning, right? And right now, it will be held regarding to the anniversary of both National Cardiovascular Center, Harapan Kita Hospital, as well as the Indonesian Heart Associations at the same time. Then we have some serial of webinar and course as well. This morning we have another course of ECMO, applying ECMO in the COVID-19 pandemic setting. Then we have another webinar for the general practitioner as well. The most important thing for us today, I think, is more than 600 participants in this kind of very important meeting. I believe that it will be beneficial for the either general practitioners or any specialists who interested in the cardiovascular disease. I really appreciate not only for the organizing committee, but great appreciation to the Pak Bob and colleagues from Daria Varia, right? I think that because of sponsorship from the Daria Varia, we can hold this very, very important webinar series, right? I think it is not the first time, so we have another 4 consecutive meeting, right? Series as well. Again, I would like to great appreciations to the Pak Bob and colleagues for supporting us. Then another important thing that we would like to highlight in this kind of series, I think this is the first time, so we have a special course, right, with some series of knowledge and skill. This is a very, very important, especially for the young doctors, and then the primary physician doctors who works in the primary health cares or in the hospital. So on behalf of the Board of Directors of National Cardiovascular Centers, again, we would like to thank for the participating, all of the participants, to our sponsor, as well as for the Department of Cardiology who hold this kind of very important meeting. Then last but not least, to Professor Elisito from Padua University, we would like to great appreciation for your contributions in this important meeting. And to the all participants, we just hope that just enjoy that very important course. Hopefully it could be beneficial for you in your daily practice. Thank you very much.
Yeah. Thank you very much, Dr. Iwan. Now we are already reaching 1,000 participants full. You see, 1,015. That includes this panelists. So I think the rest of our colleagues that would join this meeting will be directed directly to YouTube, because up to yesterday, so our colleagues that would like to join this event is reaching 3,000. So hopefully everybody can join this, even that's with through the YouTube channel. Still, hopefully you have a good quality, and later on, our team will share the link for the next events, so for the next sessions. So at second opening seat, I would like to ask our Vice President of Indonesian Heart Association, Dr. Radityo Prakoso, on behalf of Indonesian Heart Association, and there's apologize for Dr. Isman cannot our President of Indonesian Heart Association cannot attend this meeting right now, but will be represented by Dr. Radityo Prakoso. He's a consultant cardiologist. His specialty in pediatric cardiology and congenital heart disease. He's doing a lot of difficult intervention in the patient with congenital heart disease, from childhood to adult, and also especially in this field, it's very important to have very well understanding of cardiac auscultation, in which if you want to really able to clearly diagnose the patient with congenital heart disease, then the cardiac auscultation is the answer. So please, Dr. Radit, it's time for you.
Thank you, Dr. Enan. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, our college, ladies and gentlemen. Good morning, Professor Iliseto. Thank you to everyone for being here today. I'm replacing Dr. Isman Firdaus as chairman because of his condition. May he get well soon. Such an honor to me to speak in this event of the cardiac auscultation and heart sound course, serial virtual learning and with international expert. Before we get started, I would like to express my appreciations to the course director, Prof. Sabino Iliseto from Padova University, Italia. And also, we would like to thank Dr. Iwan Dakota as President Director of the National Cardiac Center Harapan Kita, and Dr. Renan Sukmawan as head of the cardiology department. In today's webinar, with our series, 4 weeks series of webinar, I think we can learn a lot about the cardiac auscultation, maybe meticulously with the Professor Iliseto, including that in my field, pediatric cardiology, about auscultation is the core of the making bedside diagnosis before we get another imaging, such as echocardiography. In Indonesia now, there are 1,400 cardiologists. I think it's very important to refresh again about the cardiac auscultation and heart sounds. Also, for our GP in all over Indonesia, I think since the attendees is 3,000 participants, I think it will be beneficial to increase our knowledge about the diagnosis. Well, I don't want to take too much of our time. I need to hand over to the next session. I would like once more, on behalf of the 62th anniversary of Indonesian Heart Association, in conjunction with 35th National Cardiovascular Center Harapan Kita's anniversary, and also 44th anniversary of Department Cardiology and Vascular Medicine, Universitas Indonesia. Welcome. And last but not least, thank you for the Daria Faria, especially Pak Bob as a PhD director, and all the team that have organized and making this event possible. Hope you enjoy this event. Thank you very much.
Okay, thank you very much, Dr. Adityo. It's an honor to have you as a representative of Indonesian Heart Association. And my colleagues, ladies and gentlemen, this event cannot be held without great support from Daria Faria. And you know, Daria Faria always provide a great educational support for many fields, not only cardiology, but many fields, I know. And as you see now, we don't talk about Daria Faria's product at all. But again, you see how Daria support this event to increase our knowledge, to increase the English or Indonesian doctors, especially to do auscultation in the well manner, and then to improve our knowledge in all fields. So at this time around, I want to ask Mr. Bob Barrera, he's a PhD director of Daria Varia, to deliver his opening speech. Please, Mr. Bob, time's yours.
Thank you very much, Dr. Renan. Yeah, salamat siyang, dear doctors, friends, and partners in healthcare. First and foremost, let's give honor and praise to God Almighty for His abundant grace and for His loving protection for us and our families, and for blessing this virtual gathering. And on behalf of your partners in Daria Varia, allow me to congratulate the organizers of this special learning course, which is a series of virtual sessions on cardiac auscultation and heart sound that will surely enhance the knowledge and expertise of all participants. This gathering is made even more special because this activity is part of this year's anniversary celebration and offering to all of you from the three premier institutions in cardiology: the National Cardiovascular Center, Harapan Kita, the Indonesian Heart Association, and the Department of Cardiology and Vascular Medicine, Faculty of Medicine, Universitas Indonesia. So from your friends and partners in Daria Varia, happy anniversary and more power to the officers and members of these prestigious institutions. We are honored to be part of this special celebration, and we are most happy to be your partner in this learning endeavor. And at this point, dear doctors, I'd like to thank and acknowledge our distinguished leaders and our guest speaker for this afternoon. So to the President, Director of National Cardiovascular Center, Harapan Kita, Dr. Iwan Dakota, Specialist Jantung dan Pembuluh Darah Consultant, Magister Administrasi Rumah Sakit. Thank you very much, Dr. Iwan. To the President of Indonesian Heart Association, Dr. Radityo Prakoso, Specialist Jantung dan Pembuluh Darah Consultant. Thank you very much, Dr. Radityo. The head of the Cardiology Department and Vascular Medicine, Faculty of Medicine, University of Indonesia, Dr. Renan Sokmawan, Specialist Jantung dan Pembuluh Darah Consultant, PhD, Magister Administrasi Rumah Sakit, and Dr. Renan is also our moderator for this afternoon. So Dr. Renan is all around, no? And has been really working hard together with his team and his organizing committee to make this program really successful. So Dr. Renan and to the organizing committee, thank you very much. Dear doctors, we are privileged to have with us an esteemed international speaker and expert in the field of cardiology from the University of Padua, Italy. He is a fellow of the American College of Cardiology, a fellow of the European Society of Cardiology. And I think most of you already know and have had the chance to listen to his lectures. Yeah. So welcome and thank you very much, Professor Ilicheto, for always accommodating our invitation and always willing to share your expertise to all of us. And we are looking forward to another productive learning session with you. Now, dear doctors, in this very important gathering, I'd like to take the opportunity to reaffirm Daria Varia's commitment to fully support you, our partners in the medical community, in your continuous quest to hone your craft. We are one with you in your noble efforts to better serve the Indonesian patients with cardiovascular conditions, even in these very challenging times. Rest assured that we'll continue to find ways on how we can provide relevant programs and solutions so that the patients that we serve together can reap the full benefits of our products, services, and our expertise. We are fully committed to this partnership because we in Daria Varia firmly believe that as one Versato family, we can build a healthier Indonesia. Again, congratulations and wishing everyone a productive meeting. Thank you. Terima kasih banyak, dear doctors.
Okay, thank you, Mr. Bob. We call sometime Pak Bob because it's already take quite a long time in Indonesia. Hopefully you enjoy our meal, especially spicy one. I think you're from Philippines and you know sometimes spicy Indonesian spicy quite similar to Philippine, right? Okay, thanks
Yes.
again, Mr. Bob. And also the team of Daria that are supporting this event to be implemented, and then we can have this session today. My colleagues, ladies and gentlemen, without you, I would like to share our gratitude to the presence of Professor Sabino Iliseto. Professor Iliseto is one of, I would say, big name in Europe. He's chief of cardiology at Padua University or Padova University in English, sometimes you call. And if you are not really familiar, Padua or Padova is close to Venice. If you go to Venice, then absolutely will close to Padua area. And Professor Iliseto graduates from Bari University and has lots of experience, taking some experience also abroad, going to New York, San Diego, USA, and also published a lot of paper. Even I personally, when I'm doing PhD, I use his some of his paper to my experiments. So he's a member of many cardiac association in Italy, in Europe, as well as in America. So, Professor Iliseto, it's now time for you to start your lecture. Just to remind my colleagues, participants are now reaching full thousands more participants, and some of them will join through YouTube. I strongly suggest you to use headset or earphone because it's make you hear clearly, especially low pitch hard sound. So then you can interact with us, with me, especially as a moderator through the Q&A. If you have any question, and please post your question directly. We will have, let's say, some informal session. Please take your time, and you can have some of your coffee or water around you, and just to make you enjoying the session, to clearly hear what the lecture as well as the hard sound that will be appearing later on. Okay, Professor Iliseto, it's time for you now to start the lecture and then interaction later on. Please, Professor Iliseto.
First of all, I like to thank the organizer and all the people that has make possible this meeting, and in particular the organizer, my moderator friend, Dr. Renan, the cardiologist in Indonesia, and Daria Varia, of course, because of the vision that Daria Varia has had. Before starting, I want to share with you some of the feeling that are in my mind at the moment. The feeling is related to what is in my mind related to what's the role of I think that there is an error of the slides that are going to be presented at the moment. I don't know why these are presented. Okay, so I think that here, yes, there is a clip that is commonly used to present Padua University. And okay, so if you can go ahead with this clip, and then I shall take care about starting my speech.
Please. I cannot hear the sound.
Yeah, I don't know. I think that this is broadcasted from Indonesia, if I remember well, as an organization aspect. But okay, we can stop this movie is not fundamental. So if you can please switch off this movie. Okay. So before going ahead with my talk, I want to share with you some feeling I have about the strategic moment in which we are and why auscultation should be the object of such an attention. And that's the reason why I am grateful to Daria Vario for the vision that they have. So in this moment, I think there is something very strange that is occurring. From one side, there is the evolution of cardiology that is strongly addressed to new technologies, like, for example, magnetic resonance imaging. But at the same time, traditional aspects of cardiology have been progressively lost in the last few years. And this has been a problem. But today is even more a problem because the pandemic situation in which we are impose a new approach to cardiology, because not for everyone is possible to have access to the hospital, to the organization diagnostic platform, and more cardiologists should be involved in a clinical approach to patients, and this will make the clinical tradition more and more important. Because of this vision, personal vision, I have reorganized the School of Cardiology in Padova, and I am the chair of School of Cardiology, giving more and more importance to the clinical preparation of the fellows, because I'm convinced that in the next few years, we shall be much more involved in clinical approach than in advanced technology. This does not mean that advanced technology should be ignored, but means that we have not to forget something that is of fundamental importance in our clinical tradition. So let's start with okay, so let me prepare the first slide because, okay, just one second, because I'm, okay, good. So now, okay, now we are. So why a course on cardiac auscultation? Because I think that is important to return and to reevaluate traditional approach of cardiology. I'm very much interested in very advanced technology like magnetic resonance imaging. And I think that is fantastic to be capable to approach new technology without forgetting the tradition. So this first slide was designed 25 years ago in the United States, when the conviction that the cardiac auscultation was no longer useful became more and more important. And because of this conviction, the training of cardiac auscultation was ignored, progressively ignored, both in the School of Internal Medicine and surprisingly also in School of Cardiology. This is something that has been the object of strategic reevaluation in important context when traditional professors were involved in trying to have a look to the future. And the concept that at that time, at least 20 years ago, was that the modern approach of cardiology is based on a diagnostic procedure. One diagnostic procedure usually make another diagnostic procedure necessary. And because of this, there is a progression of diagnosis with technology without any kind of filter. And that's the reason why at that time, 20 years ago, it was taught that it's necessary to teach physical diagnosis, and cardiac auscultation is the fundamental aspect in cardiology, in order to relearn if necessary. But this means that also teachers need to be formed. And this was written 20 years ago. And if one day we shall lose this potential in terms of teaching, cardiac auscultation will disappear. And so again, I'm happy about the vision of my Indonesian friends in this context. So in this part of my presentation, I shall face with you two aspects that are history and methodology. My friend Renan, Dr. Renan, we have decided that this has to be a very informal talk, very informal meeting, and I'm happy about that. And periodically, I shall stop giving Dr. Renan the possibility to interact with colleagues and to collect questions and answers when I think that is a strategic moment. So, Dr. Renan, please interrupt me anytime you think appropriate if you want to ask a question, because we have to be as much as interactive as possible. Okay. So let's start with the history of cardiac auscultation, because we cannot see the future if we don't know the history of something. So everything started 200 years ago when auscultation was in France used as a contact methodology. So in other words, the ear of the doctor in contact with the thorax. But this was progressively abandoned because it was considered risky for the doctor when infectious disease were present. So something that is very, very close to our situation today. But the real revolution happened years later with Professor Laennec. Laennec was a young fellow that during the clinical round with his professor had one idea. It took the paper of the clinical description of a patient. It transformed the paper in a tube, really a tube, and he used the tube close to the ear, attached to the chest, in order to collect sounds directly from the chest without being obliged to touch the patient. And then he realized that this was successful. And because of this, he moved to something that was more sophisticated. And sometimes on old painting, you can see a wood cylinder used as a stethoscope. And then step by step, the story of the stethoscope, that is the story of cardiac auscultation, became progressively more sophisticated. Austin Flint, and still nowadays we have a very important murmur that is called the Austin Flint murmur. We shall discuss this during our course, which is the Austin Flint. Designed a more sophisticated wood cylinder, but still was a wood cylinder. Then the wood cylinder was modified to have sounds going to both ears in order to create a sort of stereophonic appreciation. But the real revolution came years later when the wood was substituted with flexible rubber tubes. Then another important step, the bell. And during today's course presentation, I shall discuss with you of the importance of the diaphragm and the bell. Just to open a small window. Today, we shall speak about history, methodology, normal heart sounds, abnormal heart sounds, and we shall start with one cardiac disease that usually is considered the most important for cardiac auscultation, that is mitral stenosis, one of the most, I should say, complete partner auscultation existing. Then the diaphragm. And so at the beginning of the last century, two pieces were created, the diaphragm and the bell. We shall return in a moment to understand why the diaphragm and why the bell. Bell and diaphragm in the same instrument, then two components in the same instrument. And here we have someone that has become famous because of the stethoscope he designed, was Professor Lytham, and nowadays the Lytham stethoscope is still one of the most used in the world. Then step to step, we go to the one that I consider the most sophisticated one, and is the three components of the Tychus, that personally is the one that I use. Is a stethoscope with three pieces, is extremely sophisticated because we have the diaphragm, the bell, and a special diaphragm for intermediate sound. So let's go to the methodology. Methodology in cardiac auscultation is fundamental. What I try to explain to my student is that cardiac auscultation is not a casual approach to the patient. The understanding in our brain of the meaning of what we are listening from the chest of a patient is the result of where we are on the chest, we have to put in our mind, where the murmur is irradiated, if it's irradiated, why, if we listen better with the diaphragm or the bell, and which is the reaction of the murmur to some specific physical maneuver. So auscultation has to be done using diaphragm and bell appropriately. And let me return just appropriately, and more than anything else, to the proper use of diaphragm and stethoscope. So let's see this aspect first. The diaphragm, okay, the diaphragm is commonly used for first sound, ejection click, mid-systolic opening snap, everything that is high frequency murmur. On the other end, the bell should be used for sounds that are of low frequency, like the third, the fourth sound, the diastolic rumble in mitral stenosis, presystolic murmur in mitral stenosis, the so-called Austin Flint. So let me share with you now some slides that are related to the progression of the sound on the chest. I ask you the favor to wait for some minutes, a couple of minutes, because I have to identify slides that I'm going to present to you. And this will a matter of really few seconds. In the meantime, Dr. Renan, if you want to take care about our friends, and I should attend to you very quickly.
Oke, Mike Lis, teman-teman saya pakai bahasa Indonesia saja ya. Jadi Prof. Eliseto akan setting sedikit slide-nya. Kalau teman-teman ada pertanyaan, silahkan ajukan di Q&A. Bisa dalam bahasa Indonesia, bisa dalam bahasa Inggris. Kita buat situasinya informal saja, ya. Or if anybody from panelists want to pose question, please. Ya, sekali lagi teman-teman, kalau ada yang ditanyakan dari slide Profesor Eliseto tadi, silahkan tulis di Q&A, nanti kita jawab dan kita bahas. Ya, makasih.
Okay, if we are ready,
okay,
we
please.
can. I shall go ahead. And Dr. Renan,
yes.
We should do very frequently that I should be obliged to stop for a few seconds to load appropriate slides and then to go ahead.
Okay,
so
please.
Let me return on history and methodology. Okay, this is the three pieces stethoscope that I'm using. As you can see, there is the bell, the diaphragm, and something that is a mix of a bell and diaphragm. So the first point is that diaphragm and bell, as I told you, have different aims. The diaphragm is used for high frequency sound, and during the course I shall highlight what does it mean high frequency. High frequency means something that is like ta. This is an high frequency sound, like the snap, the open snap, ta. Why low frequency sound is something like boom, boom, boom is the third sound. you cannot hear a third sound with the diaphragm. You can miss.
Prof. Eliseto, we cannot see your slide.
Okay, sorry. Okay, please, Dr. Renan, if there is something that,
Okay.
as I told you, we have to consider this very, very, okay, this is my fault. Is clear now?
Yeah. So
okay, sorry.
maybe
Sorry.
you need to back one or two slides
Okay, yeah, because
when you start showing
okay.
some stethoscope.
Okay, this is the
Yeah, this one. Okay.
Okay, please, Dr. Renan,
Yeah,
interrupt
understood.
me if I make some error, because
Okay.
I'm going from one slide key to the other slide key and moving from one slide key to the other. Perhaps I forget to push some button. So please
Okay.
understand. Okay, but since we are in a friend environment, this is not a formal big old lecture. Please understand me. So I was describing you the three pieces is the one that I use, the diaphragm,
Yeah.
the bell, and this is a mixture of diaphragm and bell. This is the most sophisticated, and this is the so-called Tychus stethoscope. I really suggest to those that are interested in cardiac auscultation to use this one. It's much better than anyone else. So I was explaining you, sorry if I return, but perhaps it's better to return on fundamental concept. That the diaphragm, this is a lithium stethoscope, and the bell have two different functions. The diaphragm, let's go ahead, and then we should return. The diaphragm is good for first sound, ejection click, mid-systolic, hold the high frequency sound. And as I was mentioning you, and high frequency sound is like ta, ta, the ta, that is the opening snap. Or low frequency sound, like the third sound, that is boom, boom. And if you use the stethoscope, you have to pay attention to what you are using in order to filter sound, and according to where you are and what you are doing with the stethoscope, you can understand if it's a high frequency or low frequency sound. This maneuver on the right is a very simple old-fashioned maneuver. If you just put the bell on the chest, the low frequency sound detection is extremely enhanced. If you press the bell on the chest, then the bell becomes a diaphragm. And so if you hear something having the bell pressed, is high frequency. And this is important because there is something that can be heard only with high frequency, something that can be heard only with low frequency. Another things that I underline to my students is that this is not a good way to take with you the stethoscope, because the stethoscope diaphragm is very delicate. And if you use the stethoscope in this way, you can destroy the surface of the diaphragm. And this way, you will appreciate less and less clarity of sounds. So let's now move to the methodology. So methodology means the combination of different aspects that have to be re-evaluated in your brain, and according to what you listen and where you listen and how you modify what you listen, then you will understand. So this is what I teach to my student, and this is the sequence of cardiac auscultation that I use. I was trained in this way when I was a very young fellow, when I was in the United States in a pediatric cardiology division. At that time, my tutor was an old Chinese doctor, Dr. Liu. I have to recognize her value in my medical training. And these are the rules that I learned at that time, and I'm still using that. So you have to start with position A. Position A is the aortic area, because in congenital heart disease, sometimes it's difficult to distinguish the origin of sounds, but on the aortic root, almost everything is filtered and you listen only the second sound, the aortic component on the second sound. Then you have to move to B, that is the pulmonic area, where you can appreciate in the kids the splitting of the second heart sound, or the fixed splitting of the second heart sound in some congenital heart disease as atrial septal defect. But above all, in the old patient, you can appreciate an increased intensity of the sound if compared to A. And if this is happened, this is an indirect sign of pulmonary hypertension. Then you move to C, that is the area where a mixture of auscultation findings can be present. Usually is the place where aortic regurgitation is better heard, or in any case, you start listening sounds related to the left ventricle or mitral area. D is the apex, and when you hear something at the apex, like for example, a murmur that could be due to mitral regurgitation, then you have to go to E, F, and G, that are anterior, middle, and posterior axillary area, where if the murmur is progressively heard and irradiated, it means that there is the possibility of important left atrial enlargement. Then you will return to D, because you need to synthesize sounds collected in previous area. And if necessary, you will move to H, that is the area of tricuspid valve, in order to see if there is a murmur of something that increase after respiratory maneuver, like the Rivera-Carvalho maneuver, that usually are related to the presence of tricuspid regurgitation. So it's easy to understand that the complete cardiac auscultation in a patient that have, of course, murmur and abnormal sounds will take not less than 7-10 minutes. And then, usually, when you hear something, perhaps you are obliged to return to previous area in order to make comparison. So I shall stop in one moment to give Dr. Renan the possibility to get questions, but also for our Dr. Renan interaction. So the final concept are, number one, we need to reevaluate cardiac auscultation because we need an easy filter that can be done everywhere. But cardiac auscultation is the expression of a clinical evaluation, approach to evaluation. Secondly, cardiac auscultation is a fundamental step of the clinical approach to the patient, and even from the psychological point of view, is good for the patient because I understand that there is a physical contact between the doctor and himself or herself. And cardiac auscultation, in order to be properly done, is a mixture of methodology, and methodology means where you are, where the radiation is, what you are using, diaphragm or valve, and what maneuver, as you will see in a moment, you are doing. So I should stop here, Dr. Renan, and
okay.
If there are questions or even your comments,
Yeah.
I will be happy to interrupt.
Yeah, there are lots of questions already raised here, and even some basic understanding. Is very important question. First, from our colleagues, Dr. Mirhansah Perdana, he would ask, he wrote in Bahasa Indonesia, how to know S2 increase, frequency S2, second sound increase, and how to make comparison with the other. Which part is the comparison? Could you explain more?
Okay. Yeah, no,
okay.
Okay. No. Okay. My two big enthusiastic area are cardiac auscultation and magnetic resonance imaging. So just the opposite. So I'm happy to speak about this thing. So usually if we want to make if you want to make an evaluation of the intensity of the second heart sound, you have to make comparison. So usually, if the second heart sound is better heard on B, it's an expression of elevation of pressures in the pulmonary artery. Of course, this is not echocardiography. This is not cardiac catheterization. Everything has to be considered in terms of proximity. And if we have a patient, for example, with heart failure that is decompensated, and we have a second heart sound that is greater here than here, it's easy to predict that there is elevation of pulmonary pressure. On the other end, but we shall discuss this when we shall face with aortic stenosis, for example. In aortic stenosis, the aortic component of the second sound has an evolution throughout the medical history of the patient that is very, very unique, because at the beginning, when there is no stenosis, the heart sound has, the second sound has a certain intensity. Then the valve starts to become thickened with a modest gradient, and the second sound become stronger because the valve is more thickened, and when there is a leaflet coaptation, this produces a greater sound. Then the valve becomes calcific and still capable to move. Then there is a sort of metallic sound that is the result of calcium that knocks another calcium. But then the valve becomes rigid, strong, and no longer movement. And that's the moment in which second heart sound disappears. And the murmur becomes very important. So the intensity of the second sound is the result of comparison, understanding of the disease, and evaluation in terms also of the type of sounds that can be strong and metallic. And usually when something like this occurs, is because there is calcium.
Okay. I think we will discuss later on when we are there about the valve, specific valve, especially aorta and pulmonary. But if you have time, there's another question here about how to get optimal auscultation in the point of EFG, and is it preferable a particular intercostal space?
Can you repeat the optimal auscultation in
EFG, so the axillary area? So your point, EFG. Okay. Back to your slide. Back to your the ABCD, EFG.
Okay. No, I perfectly remember. I have not the slide in front of me, but it's okay. So usually, if you want to emphasize the irradiation through axilla, that is an expression of atrial enlargement. So you don't need echo to understand the result. You make a good evaluation. You have to have the patient lying on the left side. So have to put it in this way. And then you have to be very close to the patient because you have to put the diaphragm progressively from the apex to the anterior, middle, and posterior line of the axilla. But you have to do this not with the patient lying supine, but with the patient turned on the left part of his body so that you emphasize. This means that with the stethoscope, when you are on the posterior axilla, you have to put the stethoscope between the axilla and the lying bed. So this maneuver is very important. If you want to appreciate this, you have to turn the patient on the left.
Okay, so very important to make move our patient's position to enable us to hear better. Okay.
Absolutely.
So because we have lots of remaining questions, and I think you have still a couple of lecture, I think we shall continue, and then I will back later on to the question answer.
Okay. So Dr. Renan, allow me to move to another file. So I need a few seconds to do this. And okay. So now we shall start with something that we shall do very often during this course, and test. This will be done during each lesson, but the last lesson will be made of a lot of tests and interaction on the test. So, Dr. Renan, do you see test number 1?
Yeah, I can see clearly. Oke, teman-teman, kita akan tes, nanti pencet saja di jawabannya. Oke.
So the test work in this way. So first of all, from this moment on, we are broadcasting sounds. So I strongly suggest you to use earphone, because the test, the sounds have to be appreciated in a way similar to what we do with the patient. We need to avoid external sounds. We need to have earphone. So please wear your earphone. So what I should do now, and I should do many times during the course and in the last lesson a lot of times, now I shall broadcast 2 tests. For each test I shall do the following. First, I shall send to you a cardiac sound. Then I shall show you 4 possible solutions, and then I shall give you 30 seconds to give you the possibility to mark on your computer what you think that is the appropriate auscultation funding. And then I shall show you the graphs with the explanation. So let's start with the test number 1, because then the procedure and the methodology of the test will become very clear. So please concentrate. I'm going to show you the auscultation funding number 1. Okay, so I want to show you again. So another time, please concentrate. So these are the 4 questions, the possible, I give you these 4 possible answers, and I ask you in a moment to use okay, if you can please clean.
Oke.
Now it's
silakan.
clean.
Oke, teman-teman bisa tersentuh aja salah satu, nanti kita lihat statistiknya terakhir ya. Silakan, yang pakai handphone atau touchscreen.
I shall give you still 20 seconds to vote. Please vote.
Silakan teman-teman dipencet saja di touchscreen-nya ya, atau yang pakai laptop barangkali pakai mouse-nya, ditekan aja di situ. Mudah-mudahan bisa. Nanti kita akan lihat grafik.
I'm following the voting. In this moment, 53% of colleagues have answered, so almost 600. I wait for the others. Please vote.
Silakan yang belum silakan dipilih salah satu, di touch saja, yang pakai touchscreen, pakai HP atau pakai iPad ya. Sementara yang lain yang pakai laptop bisa pakai mouse-nya.
Okay, still some time. Okay, I think that we can stop now, because almost 700 people give an answer, and this is what. Okay, so
nice.
Do you see the results?
Yeah, okay. Clearly.
Okay, fine. Very interesting.
Fine.
So this is the most interesting part of this course, and when I usually do something like that. So we have 1/5 that says mitral valve prolapse, an equal number on mitral stenosis and aortic stenosis or regurgitation.
Higher aortic stenosis, I think the most. I think the highest is the third one, right?
Okay, so red means that
yeah.
So let's see where the truth is. So possibility number 1 was mitral valve prolapse. Possibility number 2, mitral stenosis. Possibility number 3, aortic stenosis plus regurgitation. So I stop the sharing, and then we go on the tracing that is this one. So this is the tracing. Then we shall go in detail because I shall listen. So this is a very old but extremely important methodology. Is phonocardiography.
Yeah, ini adalah
phonocardiography. This is the tracing of what we have heard.
Yeah, not so many Indonesian knows this equipment.
Renan, it's the same all over the world. I have to explain to my fellows what a phonocardiogram is. Okay, so let me explain. This is a tracing in which we have the recording of the murmur and the sounds. So let's go, let's take this. This is a cycle, this is another, and let me go step by step. This is the first sound, this is the second sound. First sound, second sound. First sound, second sound. First sound, second sound. This is a murmur that is called diamond shape because it's like a diamond. Diamond shape systolic ejection murmur. And you will see how different is this murmur from the regurgitant murmur. Because the regurgitant murmur, as you will see in the next lesson, will cover the entire systole, while ejection increase and decrease. And when the sound is made in this way, it means that is ejection. And what can create an ejection murmur in systole? We shall return on this on the moment. Then we have the second sound, and this is diastole, from the second sound to the first sound, from the second sound to the first sound. And this is a murmur that covers half of diastole. So we have a disease that is producing ejection murmur and diastolic murmur. And when we shall learn how to qualify the murmur, this is a hard murmur, this is a high frequency murmur. The answer is aortic stenosis and aortic regurgitation. So let's listen the previous auscultation finding with the phonocardiographic tracing on it. So this is a typical example of aortic stenosis and aortic regurgitation. It cannot be mitral valve prolapse for different reasons. First of all, because there is a diastolic murmur, and the diastolic murmur does not fit with the diagnosis of mitral valve prolapse. Secondly, because mitral valve prolapse produce a systolic murmur, and this systolic murmur is late systolic, and this is a murmur that is ejection and covers almost all systole. Third, there is click that is typical for mitral valve prolapse. Fourth, and above all, there is the kind of murmur is different because this is a rush murmur, while in mitral valve prolapse is a regurgitant soft murmur. And lastly, there is something that, of course, I cannot show with the sound, but is when this murmur has been collected, because this murmur is collected and heard on the aortic area or the medium stern area for the aortic regurgitation, while the mitral valve prolapse is heard through the apex. As I told you, cardiac auscultation is a mixture of different things, and above all, where you have heard the murmur. So, since half of the people, 1/3 says mitral valve polyps, it cannot be mitral valve polyps for the reason above. Let's go to the next test. So the next test will be managed exactly in the same way. I'm going to show you the recording first. Okay, I repeat for your benefit. Please concentrate. Okay, so these are the possible question, and the possible question, as you see, are atrial septal defect, mitral stenosis, mitral valve prolapse, and aortic coarctation. Please vote.
Oke, please vote, my colleagues. Teman-teman silakan di vote. Ini tujuannya untuk melihat level understanding kita, tapi nanti akan masuk secara khusus ke dalam tiap section, dalam tiap bagian ya. So we'll go later on the each section that I just tell them to vote to know how's the level of understanding in overall, right?
So we have half of the participants already voting. I encourage to vote again.
Please put your answer. Silakan dijawab teman-teman di salah satu, pencet aja apa yang dirasakan benar untuk kita lihat level awal ini. Nanti akan masuk ke tiap section ya, waktu di bagian-bagian lecture lainnya.
Okay, I think that we can share the results, and these are the results. Most of the people thought that this is a mitral stenosis, someone an atrial septal defect, and mitral valve prolapse, a minority aortic coarctation. So I should say that we have almost sharing the possibilities. So atrial septal defect, mitral stenosis, mitral valve prolapse, but we have to consider that these are three areas of different even clinical picture. Of course, I'm showing something that is the simple auscultation without the patient, but atrial septal defect is, we are in the congenital area, mitral stenosis is in the rheumatic acquired area, mitral valve prolapse is something that is a predisposition to develop mitral valve prolapse. And Dr. Renan, one day, if you like, can have a conference on mitral valve prolapse, because it's something that make a lot of enthusiasm to my mind. So let's see what the finding is. So stop sharing, and we go now to the phonocardiography, and here we have. So we have that this is the first sound and second sound, first sound and second sound, first sound and second sound. Diastole, contrary to the previous one, is free, without murmur, no murmur, no murmur, no murmur. So it could not be mitral stenosis, because we don't have the mitral stenosis murmur. But we have something more. We have the first sound, the second sound, and here a mid-systolic click and a late systolic murmur. This is mitral valve prolapse, exactly the opposite of the previous one. And uh, it was my intention to present two auscultatory findings that should have produced erroneous results, because you have to think to the chronology of what we are hearing. And here I'm start with the recording, and you will see how the sounds and the graphs are coincident. And this is the mitral valve prolapse auscultatory finding. Please appreciate the fact that the murmur is antisystolic, is boom, ta, but is boom, click, the murmur, and the second sound. So we should make a lot of tests during this course.
Interesting. So for everybody see, that certainly is before second heart sound, right? Okay,
Dr. Rena, I'm preparing now the slide for the lesson number 1. That is the lesson on normal and abnormal tones.
Okay.
So what we have done until now is to explain how we have to approach the single patient and how cardiac auscultation is difficult, and training needs to be done. So let's go on cardiac auscultation. So this is a complicated hemodynamic tracing with phonocardiography, but just as a reminder of what we have learned in physiology on our book. So this is the phonocardiography. This is the first sound. The first sound is built by 3 components that are related to the closure of the mitral valve and the opening of the aortic valve. Because we have here the blood pressure, the pressure in the left ventricle during systole, that goes up, 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 and up. And at the beginning, it intercepts the mitral blood pressure, and when the ventricular exceed the arterial pressure, then closure occurs. And this is the first sound. The second sound is a closure of the aortic and pulmonic valve, and it occurs when ventricular pressure goes down, 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 but going down, it goes below the aortic pressure. And when the aortic pressure exceeds the left ventricular pressure, then the aortic or the pulmonic valve close, producing the second sound. But we have 2 additional sounds that are the third and the fourth. The third is due to the impact of blood in the early part of diastole, and the third sound is physiological in kids, but is always and systematical the expression of a muscle disease in older people. On the other hand, the fourth sound is the result of arterial contraction, we are in presystole, and the elevation of pressure in the left ventricle due to the contraction of the atrium. So we have the first sound, the second sound, the third sound, and the fourth sound. The third sound is physiological in kids, and in adults is expression of a disease, as well as the fourth sound. Another aspect that is important is that the second sound can be splitted during respiration. This is more common in kids than in adults, and it depends from the fact that during inspiration, the returning of blood to the right side make a delay in the contraction and in the closure of the pulmonic valve, and is simply the result of overload due to the returning of blood from the body to the right side of the heart. Sometimes the second sound can be fixed and splitted, and this is what happens in atrial septal defect. So let's go on auscultatory findings. And I shall show you where the finding has been collected in order then to position this in the clinical context. So this is a first example in a normal subject, and we shall hear now first and second sound very clearly. Okay, now we go on the pulmonic area where the splitting can be appreciated. Okay, I shall return on these two beats, because here you can see that there is first sound, second sound, first sound, second sound, but the second sound is a little bit wider with two components, differently what happens before. Because the subject is breathing, and if you concentrate, you will hear that the second sound splits periodically during the recording. So let's start again, and I shall show you. Now it's split. Now it becomes splitted. Now, sorry. As you can appreciate, the first sound is a low frequency. The second sound is more metallic. Another example, and then we can stop in discussing the first and second sound, that we show in a more emphasized way the splitting. I shall stop when the splitting occurs, and I shall return in order to facilitate understanding. Look at here. Yeah. Here we have a first sound, second sound, first sound, second sound, with the second sound that is splitted, 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 and then it will become single, single, splitted, splitted. So concentrate on what you hear, and please have a look to the tracing, because you will appreciate the splitting on the second sound. This is a normal splitting that can be easily heard area. So let's go ahead. Split it. Single. Again, split it. So the variation in time is the result of respiration. Now, another example of splitted, normal splitted, 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 single, split it again, single. So these first three examples are example of a normal auscultation on the pulmonic area. This can also be heard of the mid-thorax. But what I want to emphasize is that we have a first sound that is a loud, low frequency, boom, something like that, boom. And the second sound that is more metallic, ta, that periodically becomes ta, 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 ta. And the splitting is the results again of physiological return of blood to the right heart that cause overload, and because of the overload, delayed of the closure of the pulmonic valve. So these are the normal findings, and Dr. Renan, I think that I want to show the abnormal so that we can stop and to collect questions again.
Okay.
Okay, so what we are here now is very interesting, and we are in the C and D area. In this case, as in other during my course, you will appreciate at the beginning 3 normal hard sounds that are filtered before the pathology finding is added. And so this is an example of fourth hard sound. You will hear at the beginning normal beats, and then you will appreciate the appearance of the fourth sound that is commonly called atrial gallop. Let me show the tracing first. We have first sound, second sound, first sound, second sound, first sound, second sound, because the abnormal finding has been electronically filtered. But then we have here, you can appreciate first and second, but before the first, there is something more, is the fourth. Here is the fourth, is the fourth. And so you will hear 3 normal cycles, and then the gallop that instead of being boom-ta will be boom-ta, boom-ta. Please here concentrate, because this is an important finding. When something like this is heard, it means that arterial pressure are elevated, and usually something like this occurs when there is a huge hypertrophy of the left ventricle, and this is the results of less distensibility, like for example in hypertension and consequent hypertrophy, or in aortic stenosis and consequent hypertrophy. Let's move now to another example. Now we are on the apex. And now in a very interesting example, there are 2 consecutive on the third hard sound. Again, this is better aired on at the apex, because this is something that is related to poor performance of the left ventricle. And again, you will see 3 beats that are filtered, first and second, first and second, first and second, and then first and second and third, first and second and third, first and second and third. So this will be a gallop, but a ventricular gallop. So we have boom-ta is the normal auscultation. Boom-ta is fourth sound. Now we hear boom-ta-boom, boom-ta-boom, boom-ta-boom. This is a very bad clinical sign. When patients have something like that, is very bad, is very bad. So let's go ahead. So another example, again, it will be a gallop rhythm, ventricular gallop rhythm. Here is the new example. So this is important because this patient is tachycardic, so is a high frequency, as a third sound. So this is the typical finding of a very severe decompensated left ventricle. I want to show you this again because this is a very, very good recording of high decompensated left ventricle in a patient with heart failure. So you don't need echocardiogram. If you listen something like that, it means that contractility is very poor, ejection fraction very poor, and the congestion is there. And the third sound is the results of the left ventricle that is not capable to dilate in the early phase of diastole when flow goes from the mitral valve in the left ventricle, and high pressure will develop because of less distensibility of the left ventricle. Let's go ahead on the sound. Please note that the first 3 cycles are without any additional sound because there is electronic filtering. Then from the 4th cycle, the third sound will occur. So the additional sound in elderly people are always an expression of something wrong. Again, if there is the third sound, there is decompensation. If there is a fourth sound, there is increased stiffness because of hypertrophy. But there is one possible, relatively rare auscultation, and now I'm going to show you, is that when in a patient you have both the third and the fourth sound. And this is called four gallop, four rhythm gallop. Is the worst clinical auscultation that you can have in a patient with heart failure. And if you hear something like that, is a very, very bad ominous sign. When you hear something like that, is very, very bad. Again, as in previous example, you will see first and second, first and second, first and second. Then the fourth will appear. Fourth will appear, fourth, first and second, fourth, first and second. And from this moment on, you will see, you will appreciate fourth, first, second, third, fourth, first, second. This is a very bad sign. I shall show you this a couple of times because of the importance, because it's complex, but also because it's relatively rare. If you have something like that, you don't need echocardiogram because it's very clear. You have a heart that is almost without contractility. Fourth sound, fourth sound. I stop just for 1 second. Please appreciate the fact that now we have here, okay, fourth sound. And now we have a fourth sound, fourth sound, fourth sound, fourth sound. So I hope that this is clear, but again, I want to show you another time because it's rare. It includes all the possible sound because the sound are four, as I told you. First, number one is closure of mitral and tricuspid valve. The second is closure of aortic and pulmonary valve. The fourth is utter contraction and the stiffness of the left ventricle because of less compliance. And the third is the expression of the poor contracting left ventricle and heart failure. So I shall show you this for the last time. So let's go now to the last example in this part of my presentation. And we are dealing with something different. As I told you, the first sound is the result of a closure of mitral valve, closure of tricuspid valve, and opening of the aortic, opening of the pulmonary, because these things occur almost simultaneously. While the closure of the mitral and tricuspid valve produce a sound, opening of the aortic and pulmonary valve do not produce sound, with one exception. When the aortic valve is bicuspid, and being bicuspid and abnormal is rigid, and the opening will create what is commonly called a click, because it's high frequency sound, and the click are high frequency sound. An example is mitral valve prolapse, but the click in mitral valve prolapse is mid-systolic and is due to something else. So let me show you now a very nice example of ejection click in a bicuspid aortic valve. The click is very precox, is attached to the, we cannot say attached to the first sound, is an error, because the click, the ejection click, is part of the first sound. It's part of the first sound we never hear, except when the aortic valve is bicuspid. Don't forget that the first sound is composed by two main components that are the atrioventricular valve and semilunar opening. But the semilunar opening never produces sound except if there are either bicuspid valve or, for example, a pulmonic stenosis. So you will see now a first sound, a second sound, but then a click. First sound, second sound, and a click. This is very high frequency vibration attached to the first sound. Please appreciate. So it's a low sound, first sound, and the click is high frequency sound. Let me show you another time, please. Okay, so Dr. Renan,
Yes.
I think that we can now open a question and answer phase if you think appropriate. And
Yeah.
I'm ready and happy to give answer to eventual questions.
Yeah, I think it's very, very interesting and lots of questions here. I would read some, because we are starting with first and second heart sound, I will focus in that question. Wait a minute. Sorry. Correct. Yeah, this is a question from Dr. Sorry, I have problem with this. So this question about how long actually we have to hear, yeah, considering the appreciation of second heart sound, whether it is a normal or split or sometimes a paradoxical split or wide fixed split, what's the optimal duration to examine the heart sound? It's a basic question, Professor.
Then in the meantime, I have also had a look to question and answer by myself. And I think that, okay, I have selected someone from my side. So the splitting of the second sound, that of course has to be differentiated by additional sounds. And the two additional sounds that can create problems are those that occur after the second sound, the third sound, for example, or before the second sound, the non-ejection click, the so-called non-ejection click, because the ejection click is the aortic bicuspid valve. The non-ejection click is the mitral valve. So ignoring these two additional sounds that can have a confounding effect, and if we consider the splitting of the sound, the splitting can be absent, because in adults this is not appreciated, can be physiological, as I show you. This is very well heard in kids. But in adults, we can appreciate two other situations. That is the fixed split. The fixed split usually produces an atrial septal defect. And the other one is the paradoxical splitting that occurs in old people also. And this is due to the left bundle branch block presence. So let's speak about the fixed split. For the fixed split, you will see that is a boom tata, boom tata, boom tata, boom tata. For the paradoxical splitting, you have boom tata, but then the breathing of the patient will change that splitting, with one difference if compared to the physiological, because you have to pay attention to the breathing of the patient. Because if during inspiration the splitting is exacerbated, this is physiological. If during the inspiration the splitting is reduced, if not abolished, this is the result of paradoxical because of the left bundle branch block. Of course, since the fixed, the paradoxical, the physiological are the results of time observation, and so the question is correct. We have to pay attention at least for 1 minute, because we need to see 4 or 5 breathing cycles. And what I suggest to the colleague that make this question is to take in mind that the effect of breathing, inspiration, are not immediate. If you make a breathing, then it will take 2-3 seconds for the blood to return an increasing volume to the right side and to produce the delayed effect. The delayed effect in physiological situation will be to have the second pulmonic sound going farther. But the same will occur in paradoxical, it will go farther, but while in the first situation, will go farther from a aortic component that is in the right moment. In the second situation, will be go farther with an aortic component that is delayed because of the left bundle branch block. And so I think that 1 minute's time paying attention to breathing and the sequence is mandatory.
Okay, I think most of the question you already explained, Professor, about how to differentiate split of second heart sound and the third heart sound. As well, there are lots of questions also, but to differentiate S4, S1, and S1 with click. I think you also mentioned that click is high frequency and clearly.
Yeah, I've seen that most of the question, I've had to look to the question, are fundamental questions, because these are the logical doubts. And one is how to differentiate the ejection click from the fourth sound. Because in any case, you have the first sound and something that is either immediately before or immediately after.
Yeah.
Okay, is important for these three things, but are important. Where you are listening, the sound characteristics, and the use of the diaphragm. So the click, the ejection click, is a metallic high frequency sound. The fourth sound is a low frequency sound. And let's ignore where they are, because one is before, the other one is late after the first sound, and this could be confusing. But we call in Italian timbro, that means the quality of the sound. But if you have the diaphragm and you hear better the sound with the diaphragm, is a high frequency tone, and this is a click. But if you use the bell turning around and you hear better, you have the confirmation that it is a fourth sound. But if with the bell you don't hear anything, and pressing the bell you hear the extra sound, it means that cannot be heard with low frequency selection, that is the bell. But if you transform the bell in a diaphragm, as I show you in the slide, this will be a diaphragm, and you will select the click. So let's say, in other words, four sounds and click are one before and the other after the main component of the first sound.
One.
The timbre. The other question that I've seen in the question answer, Dr. Renan, is how to
please
differentiate the component of the second sound with the third tone, because in any case the two tones are after the hearty component of the second tone. So how do you differentiate the splitting for the third sound?
So and that's one.
This is not difficult because of the fact that the splitting will be heard of the pulmonic area, while the third sound will be heard on the apex. The splitting will be much better heard with the diaphragm, and the third sound will be much better heard with the bell. So the combination of where you are listening and how you are listening will give the answer in terms of methodology to your question. Again, what I shall stress during the entire course is that auscultation is methodology, and we have to keep in our computer, our brain, where we are listening and really what we are listening, diaphragm or bell.
There are some basic questions, Professor, I saw here. Especially, do you suggest all the time if you want to differentiate between S1 and S2, you always using palpation, pulsation, so the pulse to differentiate S1 and S2. And what if the irregular pulse?
S1 and S2 should not be difficult to be differentiated with a very simple fact. As I suggested, we have to start listening from the aortic area. In the aortic area, is almost exceptional that you can listen the first sound. And so if you start with the aortic area, you will start listening the second sound. And then you move, but the rhythm is already in your brain, and it's easy to differentiate first and second, because starting from the aortic area, you will listen the second, and then go back through the apex. The second will be with the first, that will become stronger, but then the rhythm is in your brain, and you will recognize. This is a very practical.
Yeah, it's very important suggestion, and I think we have to follow this because it's very important. We are not really only on pulse, but again, how to move our stethoscope is very important. Professor, do you need some break or something after this? You move?
Sorry, can you repeat?
Do you need some rest or break? A couple of minutes?
No. What I want to do is to stop for 5 minutes, but for a very simple reason, very practical, because I am in a place where the light is good, but I realize that it's too far from the plug. So just to put the plug. So Dr. Ren, this is very informal. I have to tell the things I say.
Okay.
So 5 minutes so that I close my video, I move the computer, I just put on the plug for 5 minutes that are useful also for me to drink a little bit of water and to be ready. Even because what we are going to discuss now is very important, is mitral stenosis, the most important auscultation. So my good friend, I'll be back in a few seconds.
Oke, teman-teman, kita break 5 menit ya. Silakan minum karena nanti kita akan masuk ke bagian yang sangat penting yaitu mitral valve. Jadi pertanyaan tadi, yang pertanyaan awal tadi itu lebih banyak untuk menggiring kita ke gambaran secara umum, auscultation. Kita mulai secara sistematis, mulai dari first and second heart sound, bagaimana terjadinya split, klik ya, S3, S4 dan sebagainya. Tapi nanti kita akan masuk ke tiap katup. Jadi sekarang kita break 5 menit, teman-teman bisa minum, ambil kopi, dan kita akan kembali karena ini kita berada di pertengahan, kita akan selesaikan katup mitral ya, kemudian nanti pada kesempatan berikutnya kita masuk ke katup-katup yang lain. Ya, silakan teman-teman untuk break dulu 5 menit, mungkin ada yang perlu minum atau ke belakang ya dan sebagainya. Sementara kita panitia nanti Dr. Sasa coba tampilkan tadi video yang nggak sempat diputar, yaitu tentang situasi di video tentang Padua University. Tadi suaranya nggak muncul ya. Ya, tadi teman-teman ada yang nggak jelas suaranya. Sebenarnya kalau pakai headset itu very clear antara first, second heart sound, bahkan split, klik dan sebagainya sangat terdengar jelas. Pakailah sekali lagi pakai headset, dan volume dari gadget Anda tolong digedein, dimaksimalkan ya, dibesarkan supaya terdengar dengan jelas. Oke, ya, ini adalah ya, mudah-mudahan suaranya terdengar jelas sekarang. Ini adalah slide video yang perkenalkan Padova area, di mana Profesor Ilis itu berasal. Ya, beberapa catatan tadi teman-teman, saya ingin mengingatkan beberapa poin yang disampaikan Prof. Jadi bagaimana kita mulai menempatkan stetoskop dari atas ya, dari aorta, pindah ke catopulmonar, turun ke bawah ke mitral, ke samping, ke lateral, dan seterusnya. Ya, sangat penting untuk kita appreciate bunyi jantung 1-2, kemudian dikaitkan dengan kemungkinan perubahan pulse ya dari irama yang berbeda, misalnya denyut jantungnya nggak beraturan pada tiap pasien ya. Yang kedua, jangan lupa dalam pemakaian bel dan diafragma. Kalau Anda terlalu menekan bel terlalu dalam, terlalu keras, maka dia akan berubah menjadi seperti diafragma ya. Sudah, silakan diputar, Dokter Sisha. Suaranya belum keluar ya? Suaranya belum keluar. Nggak keluar suaranya. Di sana, oke. Ya, coba dibenerin dulu. Ya. Sekarang teman-teman silakan kalau yang mau pindah gadget atau apa, kita berikan waktu sekitar 2 atau 3 menit lagi ya. Saya juga mohon izin ke sebentar ya. Oke.
Fredda stanza, guardi le stelle che tremano d'amore e di speranza. Ma il mio mistero è chiuso in me, il nome io nessun saprà. scioglierai lo silenzio che ti famiglia.
Okay, Dr. Renan, I'm ready to start.
Okay, please. You can start now.
So we had a nice movie in the meantime that showed how Padua is. Okay, so let's start with the last part of today's presentation that will be on mitral stenosis. Mitral stenosis deserves a lot of attention, not only because at the time in which rheumatic valve disorder were particularly diffused, but especially because it's a very complex auscultation. It's the most complete one. So this is, let me just be sure that I put the right, okay. So this is an example of mitral stenosis with echocardiogram. Those that knows echocardiography can appreciate that the valve leaflets are thickened. In this other example, we have these that are more thickened than in the other one, some small calcium area and a big left atrium. So these things can be appreciated better with the transesophageal echocardiography. It's not the subject of our presentation today, but just to show the unbelievable potential we have nowadays in performing appropriate exploration of cardiac structure with transesophageal or even with a sophisticated three-dimensional reconstruction. You can see how nicely is the mitral valve described. So let's return to our old but still extremely useful auscultation. So this is the tracing with the electrocardiogram that facilitate the identification of cardiac cycle in a patient with mitral stenosis. Let's start with the heart wave here. After the heart wave, we have the closure of the mitral valve. This is the first sound. In mitral stenosis, the first sound is usually stronger than normal because the valve is thickened, and being thickened produces a higher volume. Unless it becomes diffusely calcified, and being calcified with the loss of movement, the first sound, instead of being increased, is abolished. Then we have here systole, and here you have the second sound. As you can see, the systole is clean, no murmur, unless regurgitant murmur occur, which is not impossible in mitral stenosis. But it is important to note that after the second sound, there is this high frequency sound, the so-called opening snap, and this is an extra sound in the same position of the third sound, but cannot be confused with the third sound because the third sound is low frequency, while the opening snap is high frequency. And then the murmur, the so-called diastolic rumbling murmur, that is the murmur produced by the flow through the mitral stenotic valve that is low frequency. So summarizing, the finding in mitral stenosis are reinforced first sound, systole free, second sound, opening snap, that is the sound produced in the mitral valve when opens because it's thickened, and then the murmur. But the first sound, if the valve is strongly calcified, can disappear, but also the second sound, if the valve is extremely calcified, can be disappeared, because both the first sound and the opening snap are due to the movement of the valve. If the valve loses its movement because it's calcified, then you lose also these sounds. We shall see this thing practically. And this is a valve that is strongly calcified. Here you can appreciate the calcium. The Doppler can be useful to make measurements, and the flow velocity through the valve is an expression of the gradient. And here you have two examples. In both cases, atrial contraction is preserved. So these are patients with mitral stenosis still in sinus rhythm. But here the velocity rapidly decreases, and here the velocity decreases slowly. So this is an expression of more severe aortic mitral stenosis than this one. So let's return to auscultation. And here this is the diaphragm. Here is the valve. And the diaphragm in mitral stenosis is very useful to appreciate the characteristics of the first sound and to appreciate the presence of the opening snap, because these are high frequency sound. On the other hand, the bell is very useful, as I told you many times today, for low frequency sound. And in the mitral stenosis, this is good for the first sound if it's not extremely strong, but especially for the diastolic murmur and the so-called pre-systolic murmur. The pre-systolic murmur, as we shall hear in a moment, is the result of the contraction of the atrium against the mitral valve in late diastole during the P wave. And this reinforced through the late part of diastole is recognized as an increased loudness of the diastolic murmur. So summarizing again, the finding in mitral valve stenosis are strong first sound, free of murmur systole, opening snap early in diastole. The opening snap is followed by the murmur that is diastolic, low frequency, with a possible reinforcement in late part of diastole due to atrial contraction. Of course, if the patient is in atrial fibrillation, this component is lost. So let's go to findings. Here we have the first example that I present to your attention. And in this case, as in other cases, you will see 3 cardiac cycles that are filtered in order to give you the rhythm. And so we have first sound, second sound, first sound, second sound, first sound, second sound, then first sound, second sound, opening snap, low diastolic murmur. First sound, second sound, snap, opening snap, murmur, low frequency murmur. So let's listen this and then we shall listen again. Okay, here I have another example built in a similar way, but we start already with the snap. So we have first sound, second sound, snap, opening snap, first, second, opening, first, second, opening, first sound, opening, and then the murmur will occur. So before we heard first and second, and then everything. Now we heard with the filter, first, second, and opening snap, and then the murmur will appear. Please be concentrated, avoid the murmur around you, because the mitral stenosis murmur is a low frequency, low intensity murmur. And now the murmur. This is a regurgitant murmur, because this is not simply a mitral stenosis, but it's a mitral stenosis with regurgitant murmur. So I just anticipated the concept that systole can be not free because mitral stenosis very often travels with a mitral regurgitation. So let's listen again this case, and I shall stop before the regurgitant murmur will occur because it's not the topic of today's lesson. But this is an interesting case because it's been filtered after the second snap is already presented. So please concentrate. So I've showed you first sound, second sound, and open snap. I shall start again from the beginning, and then the murmur will occur. So we have the first sound, the second sound, the opening snap, and the low diastolic, the intensity murmur. Again, another example. So this is what happens in mitral stenosis, and I show you another example now. And you can see the best area to be heard is D, the apex, but the murmur is irradiated through E and F that are axillar, but this because in this patient, the left atrium is enlarged, and as it happens, each time that there is a mitral murmur with the atrial enlargement, the irradiation through the axilla is very, very frequently present. And as we discussed at the beginning of today's lesson, if you want to appreciate this, you have to put the stethoscope here, here, and here progressively, having the patient lying on his left side, because in this way, the heart will be moved toward the chest, and anything that is produced by the left ventricle or the mitral valve will be enhanced and the irradiation will be appreciated. So this is now a complete example of mitral stenosis. And I ask you to concentrate because we have the complete finding nowadays presented, now presented. First sound, second sound, opening snap, murmur. First sound, second sound, opening snap, murmur. What I want to show you now is what we can do when we have some doubts and we want to enhance the murmur. If in a patient with mitral stenosis, even a mild exercise is performed, what happens is that the flow will increase through the mitral valve, and increasing through the mitral valve, the murmurs will increase its volume, the intensity, and so will be much more appreciated. But in order to do this, you don't need to put the patient on the bicycle. You just need to asking the patient to make some movement of the bed, flexion from supine to sitting, supine to sitting, supine to sitting. Very, very simple exercise. You can ask to do this 10 times, lying, sitting, lying, sitting. Perhaps you can even help the patient with your hands if he's or she unable to do that, because this will produce, in any case, will increase in heart rate. And the heart rate increase will produce output, and increase output, increase flow to mitral valve. And you will see now how these produce intensity of the sound. So this is an example. This is wide lining, and see how the murmur increase in its volume. This helps a lot. Pay attention. So this is simply the effect of position changes in the bed. And this will increase the murmur, and increasing the murmur volume, everything will be easier to be appreciated. I show you another time. Exercise. This is another example of physical exercise, the same system as before.
Nice.
So as the patient becomes tachycardic, the output will increase, the flow through the mitral valve will increase, and if the flow through the mitral valve increase, then as you can easily appreciate, the murmur will increase. I show you this another time.
Nice.
Flow increase. So, as I show you, the finding of cardiac auscultation in mitral stenosis are characterized by a first sound, an opening snap that is heard in diastole, and the murmur that is low intensity, low frequency murmur. Before closing the mitral stenosis session and opening the question and answer area, I want to show you 3 slides that will emphasize additional finding in mitral stenosis. Mitral stenosis increased pressure in the left atrium because of the narrowing of the mitral valve, and this can produce increased pressure in the pulmonary circulation and to produce consequently pulmonary hypertension. The presence of increased pressure in the pulmonary artery can be appreciated cardiac auscultation by the increased intensity of second heart sound when we are using stethoscope on B, that is the pulmonic area. We already discussed this during the first part of my presentation today. So if we use a stethoscope here and we listen a strong second sound that is stronger than A, it means that the possibility of high level pressure in the pulmonary circulation is consistent. So let's see now what happens. We have here the first sound, see how low it is. And here the second sound that is very high intensity. And this gives also an answer to the colleague that before was asking us how we can differentiate first and second sound in some situation. One good modality is to listen in this area first, because in this area, for the reason that I explained above, the first sound is poorly transmitted. And so we isolated, have a filtering that is the physical filter of the chest. We only hear the second sound. So listen this increased intensity second sound of the pulmonic area. So it's strong and metallic, because the mitral the pulmonary leaflets are touching one close to the other very strongly, because the pressure is abnormally high. And so if you have mitral stenosis finding and this auscultation on the pulmonary area, we can easily say that there is a pulmonic increase of pulmonary pressure that is not unlikely in pulmonary stenosis. Let's listen again. Another situation that I already just for a minute mentioned before, but it is just to mention because we shall have a session next time totally devoted to mitral regurgitation and mitral valve prolapse, is that mitral stenosis is not necessarily isolated, can be the results of a combination of stenosis and regurgitation, and this is the typical auscultatory finding with not only the murmur of diastole, but also the systolic murmur. The first cycle is filtered, you have no regurgitation, then regurgitation will occur. But again, this is just to show you because we should spend appropriate time on mitral regurgitation. Murmur. So this is a complex auscultation because you have not only the mitral stenosis finding, but you have also the mitral regurgitation. But I don't want to go in depth in these, as in the next slide that show another ancillary finding in mitral stenosis, because this will be explored appropriately in specifically devoted lesson. The third thing that I want to show you, and then I'm finished my slides on mitral stenosis, is tricuspid regurgitation. As I told you, in mitral stenosis, it's not unlikely that there is elevation of pressure in the pulmonary artery circulation. And if this occurs, the so-called pulmonary hypertension, the overload of the right ventricle can become particularly important. And if something like this occurs, it can also occur that the right ventricle dilates, and because of this, tricuspid regurgitation occurs. I don't want to go into the detail of tricuspid regurgitation because, as I told you, this will be a topic specifically explored, but I want just to show you a few things about tricuspid regurgitation. First, that this is the area where this is better aired, that is different from this one. Secondly, that is a regurgitant systolic murmur that is very soft. But the most interesting part of the story is that it is cyclic, because as the splitting of the second sound is affected by venous return to the right heart, and this is due to the fact that when you have deep inspiration, there is an increased return of blood to the right heart. This overloads the right heart. And if tricuspid regurgitation exists, then the murmur will be elicited or increased. This maneuver has been named Rivera-Carvalho maneuver, with the name of Rivera-Carvalho, that was a famous cardiology in Mexico. So let's listen the tricuspid regurgitation. Here you can see that you have first sound, second sound, tricuspid regurgitation, then it disappears, then you return, then it disappears. And this is due to the breathing effect. Okay, I should not go into the detail of this finding, and I shall avoid to make questions on the three additional effects that I show you, because this will be specifically explored. But what I want to stress to you is that if you have a patient with mitral stenosis, we have to take care not only about the mitral stenosis, but also about some ancillary aspects that can occur. And the most important are the pulmonary hypertension, the presence of mitral regurgitation, and the presence of tricuspid regurgitation that usually travels along with the pulmonary hypertension problem. So Dr. Renan, if you want, we can start with the questions from our colleagues that are connected in this moment.
Dr. Renan, unmute, Doc.
Professor Elisito, there are more than one question. I think this is a common question. How to differentiate between how to recognize the opening snap and then how to differentiate with splitting S2. It is a common question. What is the best way to recognize that?
Okay, let's make a statement before. The fourth lesson has been built with a lot of tests and time due to questions that someone has in his mind after the lessons. So if there are things that you want to discuss and becomes important tomorrow, then we have the lesson number 4, and we can return on everything, even because as it happens in the body, most things are connected one to the other. Okay, so let's answer to the specific question. So opening snap and physiological splitting on the second sound have in common the following aspect. First, both the pulmonic component of the pulmonic component of the second sound and the opening snap are in early diastole and are high frequency. So if we reason from this point of view, there are a lot of coincident aspects, but the second sound, the splitted or second sound, can be only heard on the pulmonic area, B. While the splitting, while the opening snap, it can only be appreciated at the
mitral area.
Yeah, so the auscultation position is of fundamental
very important. Yeah. Okay. There are another question here from I think this is my seniors, is my teacher, Dr. Arieskas Ansunarta. In mitral stenosis during exercise, diastolic murmur becomes more intensive. Is it as a cause of increased pressure gradient across the mitral valve? I think
if we create, so if we perform exercise, heart rate increase. And usually in this patient, even a very little modest exercise produce a heart rate increase. The heart rate increase will increase cardiac output and the flow through the valve, and being the valve fixed is not capable to accommodate the extra flow, and the extra flow will produce an increased gradient, and the gradient will produce increased loudness of the murmur.
Yeah, I think it's clear because of the increased intensity. So there are another question differentiating in diastolic murmur. What's difference between diastolic murmur and mitral stenosis and other diseases such as aortic regurgitation? I think is another question. I think it's position.
This is an important question, and what I shall do is when I have the aortic regurgitation, I'm writing this note. During the aortic regurgitation lesson, I shall add again mitral stenosis for comparison. So just to give an answer to this question, because it's very logical, the following difference will make the difference. The first one, the most important one, will be the kind of murmur. In both instances is diastolic. But when we shall discuss about aortic regurgitation, and I shall show you the difference hearing between the two murmur, everything will become easy and clear, because one is high frequency and very high, the other one is low frequency. And high and low frequency is a matter like if you are in an orchestra and you have the bass and the violin. So they are both produced by moving your hands on a same instrument, but the sounds will be completely different. So this is the difference number 1. The difference number 2 is where, because the aortic, the mitral stenosis is better at the apex and on the axilla, especially if you put the patient on the light side, while the aortic regurgitation, but I shall show you also some slide, is better aired on the mesocardium of the middle of the chest, and the maneuver to be done to exacerbate the murmur usually are two: complete expiration and the patient flexible lying on himself. So the kind of murmur, the site of the murmur, and the maneuver will be extremely helpful to differentiate. These three things together will make the difference.
Yeah, I think it's very important to again emphasize the position of our stethoscopes and to hear the frequency and the location is very important. But this is another question from, but you will have a less session tomorrow or the next session about regurgitation, right, Professor? Because there are two questions here.
We should have next time mitral regurgitation, mitral valve.
This is also pulmonary regurgitation and aortic regurgitation from Dr. Puspita, my friend here. It's how to distinguish murmurs of pulmonary regurgitation and aortic regurgitation. So you will discuss later, right?
So we shall have on the lesson number 3, right side murmurs, and we shall include pulmonary regurgitation and tricuspid regurgitation, plus strange findings in the lesson number 3. Okay,
Dr. Puspita, just keep your question for the third session. So there's another question, I think lots of questions here, especially how to maneuvering using stethoscope in those very obese or the one with the patient with a pregnant female. So there's another question about that.
So I'm not able to make miracles. If the patient is obese or has emphysema, by definition there is a poor sound transmission. And unfortunately, for the obese patient, the problem also exists with echocardiography. And so the answer is eat well, make exercise, and avoid to be obese, because everything becomes difficult from the diagnosis to treatment. I have no solution. I have no solution.
I think again, you have to try to maneuver the patient, right? For example, with left decubitus, etc.
Yes, of course, because this maneuver are commonly used to enhance findings. And be also used in obese patient, but the success rate is low.
There are another question about still how, when auscultation, this is a very basic question also, should we directly use both diaphragm and bell, and how to let's say play it, whether when you start with diaphragm or directly going with the bell? This is very
okay. Now this is a good question. This is a good question. All the auscultation starts and finish with the diaphragm. The diaphragm is the leader. We have to use diaphragm, and then we have to move from diaphragm to the bell. Either if there is something that we want to understand better, and we want to understand if by chance it's a louder tone, or if you are looking for something that we don't hear with the diaphragm, and we think that according to the disease can be appropriate. For example, if you have a patient with previous myocardial infarction and use the diaphragm, we shall hear first and second, first and second, first and second. But then in that patient, it's mandatory to look for additional sounds, because the cardiac pathophysiology in that instance not unlikely will produce a fourth sound or a third sound, and then you have to look for. Or for example, if you have a patient with hypertension or aortic stenosis, you have not to expect a third sound, but you want to listen if by chance there is a stiffness due to atrial contraction, and then you use the bell in order to detect the fourth. But then you have to do this properly, because the sounds has to be, the bell has to be used on the apex if you want to look for the third, or in the mesocardium if you're looking to the fourth. So a long story to give a very specific answer. Diaphragm is the main, and the bell has to be used either for a better interpretation, or if you are looking for something in your mind is not unlikely to be found in that specific patient.
Yeah, thank you, Professor. This is also a continuing question. I think this is very important and mostly asked by somebody, some of our colleagues. When auscultating children, should we use the stethoscope specific for children or just using the adult stethoscope with bell parts in common stethoscope? What do you think?
Now, if there are very small kids, we have to use the small stethoscope, because otherwise the diaphragm is too wide.
Yeah.
And so this is a very small. And if you have a very small kid, don't forget to make warmer the stethoscope, because if you put something that is relatively cold, they will become so they will have a reaction. And what I usually do is to make with my breathing, to make warmer before warmer. So small tricks in order to have an acceptable reaction.
Yeah, very interesting. I think a small trick, but it's very important. So I think I will go to the last question. This session is about, this is very important. You show that if you put the stethoscope in one of your picture, and then the bells down to the closed, and then not the bell, the diaphragm. The diaphragm will eventually will broken. So how you suggest to bring the stethoscope?
Okay, so it's a very practical suggestion. Yeah. And there is also a paper that has been published recently that states that we have to clean the stethoscope in the COVID area, because the means of transmission from one patient to the other. But apart from this, now what I usually do is when I am in my sitting my desk where I have the stethoscope put somewhere else, and not turned but longer. And when I go to see patients, I put the stethoscope in my pocket. Because it's safer. Because if you put here, then this movement, before or late, in 1 month, 2 months, 1 year, will create a potential damage of the diaphragm. So the stethoscope must be respected.
Yeah, it's very important because it's our weapon.
It's our weapon that you can have everywhere.
Yeah. Okay, I think we can finish this session today. Or you have another thing to say?
No, I think that I was happy about today's session. I think, Dr. Renan, that we have to follow this format, very informal, with possible interaction. Please, let's continue in this way also next time. And if you think that I have to stop, please do that. Stop me, and it's like, an interaction. So I should be more than happy to stop and to analyze specific aspect that perhaps needs to be re-examined. What I suggest is to, if there are things that we have been unable today to answer, we can put in a basket somewhere. You are the chairman, and perhaps we can return on the specific question in the appropriate session, as we have done for 2-3 specific questions related to mitral regurgitation,
and pulmonary regurgitation. Yeah. Okay, Professor. I think I would say thank you very much. I think this is a very nice beginning of this session and very informative. And then the way you explain the things, it's very amazing for us, and it's very important. And we learn obviously from you. And we will see you again next week.
Okay.
Okay.
Good.
So
I wish you the best to my Indonesian friend, and see you on Friday, next Friday. Okay. Bye.
Thank you very much. Okay.
Bye, Dr. Ren. Okay.
See you next week. Thank you very much.
Bye.
Baik, teman-teman. Jadi minggu depan kita akan ketemu lagi pada jam 1. Jadi saya tahu bahwa ada banyak teman-teman yang nggak bisa join hari ini lewat YouTube akhirnya, tetapi nggak masalah. Saya kira kita bisa mendengarkan. Tetaplah memakai memakai jadi ikutan bel stetoskop ya, tanpa pakai headset atau earphone kita ya. Kemudian nanti mulai jam 1 memang the first come first serve. Jadi kalau teman-teman mau selalu ikut dalam session ini supaya bisa dapat seat gitu ya. Mungkin dari jam 12 sudah mulai itu ya, mulai akses barangkali ya. Nanti kemudian yang lebih dulu akan bisa masuk lebih awal. Tapi apapun itu, terima kasih atas perhatian teman-teman semua. Nanti kita akan catat semua hal-hal yang bisa dibahas lagi pada sesi-sesi berikutnya. Sekali lagi kita berharap bahwa hal-hal praktis yang kita pelajari ini nggak dilupakan dan bermanfaat untuk aktivitas klinik teman-teman dimanapun berada. Saya tahu ini pesertanya dari seluruh tanah air. Kita sangat berharap bahwa apa yang dipelajari hari ini bisa memulai teman-teman untuk lebih pede lagi mengenali ya, pede mengenali diulang ketika temu pasien-pasien, apalagi dengan murmur ya, mulai dengan posisi A, B, C, D, E, F, G tadi ya, diputar lagi. Saya kira lama-lama kita akan lebih mengenali dengan baik, kemudian mengenali ke kliennya dan lebih terbiasa lagi memainkan antara diafragma dengan bel tadi ya. Jadi ada beberapa suggestion yang saya kira penting untuk kita selalu ingat. Baik, sekali lagi terima kasih atas perhatian semuanya karena sudah lebih setengah jam. Tapi kita mendapat saya kira pelajaran yang penting bagaimana hal-hal basic ini sangat penting bahkan di negara Eropa sekalipun, maka kita pun di Indonesia harus selalu memahami ini basic ini dengan baik ya. Dan kita akan ketemu lagi minggu depan, berharap ketemu teman-teman semua dalam keadaan sehat, baik ya, dan bisa mengikuti aktivitas kita selanjutnya pada minggu-minggu mendatang. Sekali lagi terima kasih atas perhatiannya dan teman-teman juga dari Daria Varia yang selalu mengawal kita pada kegiatan ini sehingga semuanya bisa berjalan dengan baik. Selamat sore semuanya. Sampai ketemu minggu depan. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk semua.
Waalaikumsalam warahmatullahi wabarakatuh.
Sudah selesai Mas Anas? Mana Mas Anas?